Thank you very much for your invitation to talk about the relevance of the exercise as a neurorestorative treatment for Parkinsonian patients. My task is simple and complex at the same time. It is simple because it is a common experience that Parkinsonian patients improve their motor performance if they carry out a regular physical activity. On the other hand, it is complex to demonstrate the neurorestorative effect at the basis of this improvement. Are you not conflict of interest? First of all, I want to show you what happens in animals model. In 2013, Giuseppe Frazzitta published this milestone review, and she concludes that there are a lot of scientific evidences that exercise carried out on animal models of Parkinson's disease plays both a neuroprotective and a neurorestorative effect. In particular, the neurorestorative effect is due to different processes. An increase of dopamine release with the reduction of the dopamine transporters, the increase of the neurogenesis in hippocampus, the increase of the blood flow in different brain regions, and finally, the of the BDNF levels. This review shows clearly as the exercise is neurorestorative and neuroprotective in animal models of Parkinson's disease. More complex is to demonstrate the same brain modification in humans. However, we have a lot of papers that show how the risk of Parkinson's disease is reduced in subjects who perform a regular physical activity in their life. On this topic, a definitive word was written in the paper by Young, where more than 43,000 individuals provided an extensive information on physical activity and were evaluated in a very long follow-up of 12 years. The conclusion of the study was that a medium level of physical activity reduced Parkinson's disease risk. This study, in my opinion, confirmed clearly the neuroprotective effects of the exercise. Now, we have to find if the exercise is also neurorestorative. The aim of this PAC study was to examine the feasibility and safety of high-intensity treadmill exercise in patients with de novo Parkinson's disease who were not taking medication. In the study, 164 patients were enrolled in 3 different groups: high-intensity treadmill, moderate intensity treadmill, and controls. At the end of the study, after 6 months, the authors concluded that the high-intensity treadmill was feasible and safe. Most interestingly, the mean increase in UPDRS motor score in high-intensity group at the end of follow-up was 0.3 points, compared with the mean increase of 3.2 points in the control group. The difference between 2 groups was significant. This data could demonstrate a neurorestorative activity of high-intensity treadmill able to reduce the symptom progression. Another clinical study that could suggest a neurorestorative activity of the exercise is the study of my friend Pete Smith and the National Parkinson Foundation group. They enrolled more than 2,000 patients and evaluated their quality of life using the PDQ-39 and their motor performance using the time up and go test. The authors compared patients who performed regular exercise more than 2.5 hours a week with patients who perform exercise less than 2.5 hours a week. The study had a 2 years follow-up. At the end of the follow-up, the patients who carry out exercise more than 2.5 hours a week show a significant positive effect on quality of life and motor performance. This is another paper that suggests a neurorestorative effect of the exercise. With Gabriella Bertotti, I have developed a specific, intensive, multidisciplinary integrated rehabilitation treatment for Parkinsonia patients using treadmill, tube, and feedback. Its main goal is the relearning of the lost habitual motor behavior, the correct execution of the habitual automatic movement, and the recovery of the correct switching strategies from the automatic to the voluntary movement. We have tested this treatment in 40 de novo Parkinsonia patients, all treated with the same levodopa dosage at the beginning of the study. In the experimental group, 20 patients underwent the rehabilitation treatment, while the control group was treated only with drugs. The study had a 2 years follow-up. The patients in the experimental group were treated with the rehabilitation for a month at the beginning of the study and a month after 1 year. Both the treatment improved significantly the motor performance and autonomy in daily life, evaluated with UPDRS time up and go at 6-minute walking test. At the end of the follow-up, the patients in the experimental group showed a significant improvement of UPDRS 3 and 2 scores in comparison with the beginning of the study, while the control group showed no changes. Moreover, at the end of the follow-up, patients in the experimental group used a significantly lower levodopa dosage in comparison to the control group. This data could suggest a neurorestorative activity of intensive exercise. To check this hypothesis, we evaluated the BDNF serum levels in a group of patients who underwent our rehabilitation protocol for 30 days, compared with a control group that did not exercise in the same period. We found that the BDNF plasma levels evaluated at 7 o'clock AM increased significantly at the first control, and these levels were maintained for all the treatment period. This data suggests a neurorestorative activity. We know that the increase of BDNF tract B signaling in lymphocytes is highly correlated with changes in cortical excitability. The next step in our project has been to evaluate whether the exercise is effective in the increase of the BDNF tract B signaling in lymphocytes. We treated 16 patients with our rehabilitation treatment for 1 month, and we found that all patients showed a significant improvement in motor function. Moreover, TrkB interaction with NMDR and BDNF TrkB signaling increased in peripheral lymphocytes at receptor, intracellular mediator, and downstream levels. And this increase was related to a reduction in UPDRS2 and total score. Fischer published a paper where he compared 3 groups of Parkinsonian patients in early stage of disease who underwent 3 different trainings: high intensity, low intensity, and zero intensity. The aim was to evaluate a possible modification in the cortical silent period, index of corticomotor stability. The author found that a small improvement in UPDRS was observed in all groups, but only the patients in the high-intensity group show increase in all parameters considered for the study. Moreover, and most importantly, only patients in high-intensity group show lengthening in cortical silent period, index of a normalization of the corticomotor excitability. Another study by the same group examined whether intensive exercise leads to modification in dopamine T2R expression using PET imaging with 18F palipride in patients with Parkinson's disease in early stage. 4 patients were randomized to receive intensive exercise for 80 weeks or no exercise. At the end of the follow-up, the authors found in the treated patients an increase in 18F palipride dopamine T2R binding potential and an improvement in postural control. On the contrary, no changes in dopamine T2R binding potential were observed in patients who did not exercise. They concluded, suggesting that exercise can lead to neuroplasticity in dopaminergic signaling and contributes to improve function in early stage of disease. A few months ago, Johansson published a meta-synthesis of literature about the exercise-induced neuroplasticity in Parkinson's disease. A huge number of studies has been considered, about 4,000, but only 13 were included in qualitative synthesis and only 3 in quantitative synthesis. All the studies considered for qualitative synthesis that used different methods, blood sampling, brain function, and brain structure, showed a positive effect on neuroplasticity. Moreover, the 3 quantitative studies show that the overall effect size was small but positive, ranged between 0.9 and 1.8. The results indicate that different physical exercise may lead to changes in a range of markers of neuroplasticity. This suggests that both brain function and brain structure can be modified in a positive direction after an exercise period in Parkinsonian patients. I am a clinician, and I know that the most important problem of Parkinsonian patients is their very low quality of life. I have to fight with this problem every day. In this study, where we enrolled and randomized 250 patients, we found that the exercise can improve significantly all the different items of PDQ-39 scale at the end of 1 month's exercise treatment. But most importantly, we found that the great part of this improvement is maintained at the 4 months follow-up. Recently, BLAM outperformed both a scoping review and a systematic review on the genetic and disease-specific health benefits of aerobic exercise for people with Parkinson's disease. Their conclusion is that aerobic exercise improves physical fitness, reduces MDS-UPDRS score and axial symptoms, improves quality of life, and has a possible disease modification effect. The only side effect observed was an increase of the risk of fall. But we every day see the relevant drugs side effects that reduce the quality of life and increase the cost of disease. And we know the risk related to a surgical treatment. Moreover, this kind of treatment have certainly not a neurorestorative effect. Moreover, a retrospective analysis of the Parkinson Net group showed that exercise performed by specialists of Parkinson's disease reduces the Parkinson's disease complication, allows a continuity of treatment with the same physiotherapist, reduces the cost for physiotherapy and for medical expenses, and reduces the mortality. In conclusion, nobody can seriously think that exercise is not useful. Exercise has to be aerobic and cognitive, finalized to the recovery of automatic movement affected by the putamen dysfunction. We have a lot of data about the amount of weekly exercise, no less than 3 hours. Exercise is safe and permits a lower levodopa dosage with the reduction of dangerous side effects. Exercise reduces the cost of disease. The question were if the exercise is a neuroprotective, and in my opinion, the answer is yes. Thank you very much for your attention.